did you manage to read the information sheet?
Yes.
And you completed a consent form?
Your image is frozen at the moment.
Okay, I don't have very good Wi-Fi, so I'm going to switch the camera off.
I'd prefer if you didn't do that, because I do depend on lip reading. I have
okay.
profound hearing loss, and I'm using subtitles.
Okay, we'll keep it on then. So, have you completed a consent form?
Yes.
Do you have any questions or concerns about
No.
Okay, so would you mind telling me what your understanding of our research is and what you've consented to today?
Well, my understanding is that I'll be interviewed about my professional and voluntary work experiences regarding inpatient care in mental health services.
Yeah. So we're focusing on admission and discharge to mental health hospitals and what alternative services are available.
Yes, okay. It's good that you've mentioned that focus. That is my understanding.
Okay, so just a reminder about confidentiality. You will be anonymised in the report, meaning no one will know what who has said what, and any personal information won't be shared outside of the research team. You can withdraw your data until the 11th of September. Just just email me to say you would like to withdraw. You don't need to provide a reason. I will send you a debrief form at the end of the interview. If you would like to stop the interview or take a break at any time, just let me know. For the purposes of transcription, we will be recording this interview. Does this sound okay?
Yeah, that's all fine. It's just like what I consented to in the consent form.
Cool. So what do you think are the main factors contributing to admission?
Well, I think it's a combination of a lot of different factors. I mean, one is simply need related to risk and clinical assessment of needs that can be better addressed as an inpatient than in the community. But admission is also related to problems with outpatient treatment, people waiting too long or not getting the right treatment. And in particular, my experience seems to indicate that people suffering from complex trauma, a lifelong history, complicated by other health conditions usually, can result in admissions that are preventable. So you shouldn't aim to prevent all admissions. Obviously, there are some that are appropriate and where the care that's provided as an inpatient is very much necessary and needed. But I think that there's a range of factors where admissions could be prevented, including when people are discharged after inpatient care but don't get the connected support. So those types of situations are currently being considered in commissioning because of umbrella contracts that include in-reach, so that community agencies expected to support people in the community after discharge start to make contact before discharge. And that's kind of in its infancy really as an approach, certainly in the local area and the region. But it's my experience that care is not coordinated, and it's been a primary objective of NHS reform for pretty much a decade, that access to the right service at the right time can prevent preventable admission, and that care coordination can support admission and support discharge. And when either of those two fail, then it's likely that there'll be unnecessary admissions or preventable admissions and discharges that do not are not sustainable from the point of view of the individual or their families or carers. So it's a complex business, made more complex by the relationship between integrated care systems and social care support in relation to clinical care. So you know, the Independent Mental Health Network that I volunteer for has long pursued a social model, but sometimes it's been my experience that clinical considerations have overridden social care considerations. So somebody can be discharged maybe from for a physical health condition after treatment, and then their clinical follow-up to continued health care is not really appropriate to the person's social circumstances, and the social care element and the clinical element are in conflict, and then the person doesn't thrive or even has to be readmitted into residential care again. So I think it's quite a complicated issue, but you know, it really depends on good assessment, good care coordination, good onward referral, and relationships between people working in residential care and people working in the community. There are huge obstacles to that, and one of the things I've recently become aware of is research about people who are dependent on various types of medication being admitted and then not getting the medications that they're dependent on, and that produces enormously high risk of harm to the individuals. And hospital policies, especially regarding opioid medication, are not very conducive to joined up care when somebody comes from community care where they're being prescribed into residential care. And of course, there's a high prevalence of substance use among people with mental health problems, high dependency on medications, high comorbidity with other health conditions, and all of that tends to get into quite a mess. So people don't get the treatment that they need, they don't get the medications that they need, they prematurely discharge themselves at high risk to themselves, and the risks aren't really properly assessed. So there's a whole bundle of concerns really about risk. You know, then you've got to liaise between different systems like criminal justice system. If somebody's admitted to healthcare within the prison system, for example, that healthcare is delivered under a separate kind of block of commissioning from NHS England. But if they happen to be released temporarily for further health care, then they fall into a different health system, which is the national one that we all benefit from. So, and there can be terrible problems with miscommunication between the two different systems, and a lack of exchange of data, a lack of relationship. And so if somebody is admitted into the secure estate, for example, because they're a high-risk prisoner with profound problems and they can't be contained within the healthcare system inside the prison, they go to a secure estate place outside that's a mental health institution, and then there numerous problems occur with that. So it's in situations like that that families and friends and carers tend to find themselves excluded. But it doesn't only apply to those kind of situations. Professionally, I've been in situations where somebody's lived in a hostel, attempted suicide and been saved by the staff, and then taken to hospital and not retained, discharged. So in this particular episode I'm thinking of, cut down from a ligature where she tried to hang herself at around 6:15, admitted, taken to hospital in an ambulance a few minutes later, after resuscitation at the hostel, and then discharged at 3 o'clock in the morning, the next morning, onto the street. Now, that's not very appropriate, but when my staff tried to get her respite care, I hasten to add that's not within this region, it's an adjoining region. They said, "We've got no place for you," which was exactly the words that she'd used in her final goodbye letter. I don't feel there's any place for me in this world now. My gran has died. I'm off. So, you know, these miscommunications, the fact that there were professional people dealing with a situation that was much more serious than what they were qualified to deal with. Generic hostel workers are not qualified to deal with very high risk clients, very high need clients. But the communications between clinical care institutionally and the people who needed to know what was going on failed completely. They didn't communicate at all. And there are numerous incidences within my professional experience, you know, mistakes with medication that really damage the people's mental health instead of supporting it, and then they decline physically, and then they're admitted, and then there's bouncing to and fro with all different cocktail of medication, none of which were in fact needed. And when they're withdrawn after huge objections from the staff and myself, I managed to get them into hospital again and detox them from all these different medications, and then they were good again. They didn't need the medication that they'd been given. It was a wrong assumption or incorrect prescription in the first place. It caused a whole chain of problems. So this is really the fundamental thing. It's connection, communication between community agencies, carers, family, loved ones, friends, people who know the individual, people who've worked with the individual in a different context than perhaps a clinical context, and the clinical sphere, so that when they are taken in as an inpatient, there's some kind of information flow both ways, so that people know what's going on who need to know. And all too often, the excuse is made about confidentiality, patient confidentiality, but usually, if you've got somebody non-clinical working outside of a facility, an inpatient facility, the client's already agreed to disclosure of relevant information for their health or social care support. So the protocol there are confidentiality protocols between different parts of the system, social care and health, and usually that works, but sometimes that can break down and people withhold information that they should have disclosed, such as when they're going to discharge, the fact that there's no discharge plan available for workers outside of clinical situations to continue the work or support the work that's been done, or consolidate it. So admission can be fraught with difficulty. Information doesn't travel too well because of a lack of connection between the different parts of the system. Discharge You know, a lot of discharge work can be done even before admission if it's a planned admission. And the whole idea of the care plan can be worked out with the individual, with carers, with professionals who are involved in the community, and with voluntary agencies, and that can all be worked out before the person goes in, so that the plan, while they're in, can be refined and delivered as soon as they're discharged. My experience is that quite often, because of the stresses on the system, assessments aren't done early enough about what the person might need and what their carers might need on discharge. And that's something, again, in the Independent Mental Health Network that we're hearing all the time. You know, things have improved for carers since the Care Act, but quite often the cultures, especially among management, senior managers developing new systems or developing integrated care, they've been brought up in a culture where the Care Act didn't exist. And quite often carers drop off the map completely in some kind of circumstances. So if somebody's being discharged, there could have been an assessment done about their needs, but what about the impact of their recovery on the individuals who have been looking after them for years? And then, of course, the carers are at high risk themselves of breaking down and then having to be admitted to care. And then you've got a whole bunch of issues regarding whether couples can be admitted together. And there's such a shortage of that kind of facility. Then you've got all the different cohorts, the needs of young people, the lack of facility in some regions, and therefore out of area discharge or out of area admission. And then in area, if somebody's admitted and they're cared for within a particular area, if they're admitted from a place that's outside their area, they might assume that the care system that they're discharging into resembles what they're used to in their own area. But that's not always the case, you know. So how portable these things are, the postcode lottery of different standards of care in different places. I look very regularly at performance criteria, various kinds, and I've been involved with a little bit with the CQC developments and things like that, and try and get data from public health fingertips tool and things like that. And what you tend to see, especially in Surrey, and I'm looking at a new commissioning at the moment, and in Surrey, what's happening is that they're making a policy for an umbrella contract to deal with various community services. And that does have an impact on admissions and discharges, because if the system is robust enough, it will provide support on discharge. It will reach into inpatient treatment and establish relationships before the person is discharged, and that will make their discharge more robust and safe. But what's happening is that people talk about the averages for Surrey without addressing pockets of areas within Surrey where the performance is low, or where the problems are more serious, where there are groups of cohorts, minorities, ethnic minorities, social identity minorities, and so on. And this is a big problem. And in the current policy as drafted, they said, well, the thing is, suicide in Surrey has improved, and they're looking at old data. But when I look at the data, I find that London has had the least increase in suicide in the last 5 years, up till 2019, the data goes. And so from 2017 to 19, it's increased by a small percentage, 8%. When you compare England average it's a bit higher. If you compare a good area that's outside London, say in the northwest, 11%. England average 13%. Surrey, 34% increase in suicide from 2017 to 2019. Now that's not good, but people become complacent by looking at averages, and the CQC and fingertips tools look at green, good performance, orange, average performance, and red areas far below average performance. But the best performing areas in England have a much greater difference in some areas, especially mental health, different aspects of mental health treatment, have much better performance, much better quality than the orange areas or the England average. And so you've got this pernicious system where the data isn't terribly up to date. Managers aren't looking at their own data, practitioner data, team data, organizational data, and comparing it to the best and then going along to the best. Now, one of the activities that I do as a volunteer is with meme, making every adult matter. And they've got a meme approach which tries to provide integration across a whole bunch of different areas and involves people, co-production. And this is an area where I feel where Surrey could do far more in terms of co-production. In other regions that has happened, you know, and in some regions they're using client experience, carer experience, professional practitioner experience, managerial experience, community agency experience, and putting it all together and trying to work as a team across numerous different agencies. And that's the basic concept that integrated care first started with in America. You have all the agencies under one roof: police, welfare, housing, education, back to work initiatives, employment, training, health, social care, the whole panoply. And in some of these meme areas and regions, that's what's happening. You've got these big partnerships all trying to solve the most intense problems and put resources, the most resources where needed. People with profound difficulties in terms of complex trauma, histories of traumatic abuse that they received as a child, exclusion, prejudice, discrimination, trauma, all through their lives. And then that's resulted in things like substance use and homelessness. And so by focusing attention precisely where it's needed and using different models of treatment, at the moment, it's a bit upside down. If you've got a serious problem that's developed, as I have had, and as my partner has had, based on past trauma, we've both been very successful in our careers, our professional careers, but then suddenly something happens that kicks off the problem all over again, and then it's a big challenge. And I've met literally thousands of clients who've gone through the system, and they were victims before they were criminals, or their behaviour was criminalised because it's drug seeking or whatever, trying to palliate the problems of their trauma, because they didn't get what they needed. And you go along to IACT and you get 6 sessions. That is quite insulting, really. It's simplistic. You might not even get 6. They might say on the phone, well, it sounds like you've got it under control. That's it, finished. So intervention completed, 1 phone call. Now, that person might have struggled for months to even get to their GP, and the GP says, can you phone this number and they'll look after you? And they're not getting the care that they need at a very primitive primary level. Now, I'm not saying it's all like that. Things have improved, but there's bounce, People go through the first tier, say IACT, say they do get their 6 sessions, and it exposes a lot of problems. It evokes things from their past. and they realise that they're ill. And then they phone up again and say, I need more support. No, you've got to think now about the treatment that you, so we'll give you more support in 3 months if you still need it. You've got to change your thinking. Well, these people's thinking was damaged profoundly. And the symptoms of trauma, stress, disorder, inability to organise, cognitive impairment. So they lose their job or they can't work, they go on long-term sick. Stress disorder, sleeplessness, they can't attend new job interviews, or they're disorganized when they do attend them, or you know, it all kinds of starts to link. The thing becomes a complex, a whole ball of wax, you know. So now they're getting depressed, they're anxious all the time, they can't go out, they become suicidal, their social life breaks down. And now they go to their GP, or they speak to a friend and say, I want to kill myself. Well, we take you to your GP. The GP's overloaded, has no time for mental health. And now you've got somebody who's really at high risk, because suicide prevention training has indicated that part of the plan for non-qualified support is see if you can get them to go to their GP. This might be somebody at work who's had to stop working, and their manager, not got a clinical background or anything, doesn't know anything about except about the business that they're in, just taking a concern for their staff, gets them to go to the GP. GP can't answer, IAP can't answer. Well, fundamentally, the things have got to change. That person then gets admitted after trying to hang themselves or complete suicide in some way. They didn't complete it, they're admitted, they're an inpatient now. Now it's crucial that all that information and the bouncing around between systems, you know, the person might have been a drinker because they're trying to suppress, or they might use drugs, and they're heavily dependent on prescribed opioids, say methadone or something, and then they don't get what they need as an inpatient. They discharge themselves. Now they're going to huge risk. And so you see these unfortunate incidents take place. And there's another problem as well, which I'm aware of in Surrey from studying the inquest thing I mentioned earlier. I don't think enough attention is given to coroner's reports, especially in our region, but overall, nationally. And the episode that I'm aware of took place in the Abraham Cowley unit, and crucially involved somebody who was there as a voluntary patient. And the regime's different for voluntary patients. So when the person said, can I go out? They're allowed out. But that person was a huge risk patient and was an inpatient. And unfortunately, although citizens intervened, reported to the police intervened, that person was let out the same day again, because she wanted to complete suicide, and she did. Now, when that query happened, it was all a long time ago. And when you're looking at these things, say from 2017 onwards, that death might have been captured in your study. The coroner couldn't report on it until years later. And then I took up their report with the trust concerned and said, look, this report identifies a number of concerns. Where are you at with it? Oh, we've redrafted our policy about alcohol and things like this. Now, the coroner raised 4 really good points. They've answered, it seems, 2 by a redraft of policy, but that's 2 or 3 years later, and then that gets left behind. And I've asked about it again this year, and no reply, because it's still only a draft policy. Nobody knows whether clients have been engaged to co-produce an improvement. Nobody knows whether staff have been consulted about whether the improvement or the new draft is workable. So now you've got an inpatient who self-discharges, if you like, but that person could have maybe survived until the end of her treatment and then been discharged and still incredibly high risk, incredibly vulnerable, incredibly high need, but it's discharge. And what has been done to address that? And the thing is, you don't know, I don't know. So I'm wondering now, I think I better stop talking because I think I've identified enough issues for the time being. So I'm not sure if we're even live at the moment. Oh yeah, the record button's still ticking. So I don't know if you have any follow-up questions.
I do, but that was great. That was so in depth, and yes, I was just enjoying listening to you and agreeing with a lot what you said, nodding along. So, what actions prevent admissions occurring? I.e., it should have happened and didn't, or it was de-escalated and no longer needed.
Okay. Well, I think the problem is in the question, really. One of the things that is monitored is admissions. And the whole idea is, in terms of NHS reform at least, that a lot of admission is preventable. So the data then starts to be developed about admissions. Now, admissions are increasing, and I've dealt with this problem before professionally, where we talk about the problems of admission. You've got an ambulance call out, say, for an emergency, then you've got an A&E admission, and then you've got an admission to hospital. So that's 3 types of admission, if you like. And you want to reduce all that. Now, if you start off with the objective of reducing admissions, you're just causing more admissions, really, because people aren't going to get what they need. So, but what is necessary is to identify avoidable admissions, and the data doesn't really give you much of a clue on the face of it about avoidable admissions. You need to do a lot of case study and analysis and research to find out which admissions in the end would have been avoidable if the person had the right treatment in the community. So in the example that I'm thinking of, we tried to reduce unnecessary ambulance call-outs. And we succeeded over the space of 18 months, 2 years, in reducing unnecessary ambulance call-outs. And we did that by identifying who are the people who regularly subject to ambulance call-outs and trying to meet their needs better in the community. Right? So that would be my recommendation for a start, that there are some emergency calls from people known to services, known to multiple services, and if people could communicate together and compare their caseloads with each other, they would see and be able to understand that some people are what used to be called informally among ambulance crews and staff, frequent flyers. So who are the people who frequently use ambulance services? Now, we don't want to reduce admissions, but necessary admissions. Now, it just so happens that my partner suffers from severe asthma, and in relation to her mental health, if she's under huge stress, then the asthma gets worse. And in the last few years, we've gone through some stressful circumstances, and she's had some particular problems at work. And then that has resulted in intense attacks where she's been literally unable to breathe and near to death. Now, if the ambulance hadn't come, she would have died 2 or 3 times over. Once I took her to the hospital and she collapsed literally in A&E. And they just had time to ask her, did you walk across the car park? And then she fell over. She couldn't breathe anymore. So now we've got to the stage where you've identified, perhaps through liaison, in the context of mental health, with different agencies, Mind, other community agencies in Surrey, Catalyst, Mary Frances Trust, Richmond Fellowship. You've got to liaise with all those people and find out who are the people who are high risk, who are the people who are engaged in primary or secondary care, who frequently call for attention. Maybe not an ambulance call out, but maybe just phoning up before their next appointment saying, I can't make it, or going to the crisis care, the safe havens. So the safe havens know who their customers are, and they know the people in terms of who they are, but they don't know. The assessment is social, it's not clinical. They're not given clinical information. But if they have serious concerns, they can refer to a clinician, and then the clinician refers them to a service or says, well, this is very serious, we need to admit you. So then there's admission. So if you put your eye on preventing admissions, you will fail. You will fail just because of demographic change. The population is increasing. There are more and more young people. There are more and more social problems. There are more and more admissions. You know, year on year, the ambulance service and A&E admit more and more and more people, but all kinds of health reasons, including mental health. That is fact. The population has increased to such a degree that our infrastructure is just approaching a limit. Now, what happens then is attrition. So you say, well, we're going to admit only the most serious people. Now, I've worked in systems where that is a policy. In Surrey, the system for social care funding of people who need residential addiction treatment. It's not clinically funded, it's social funded for whatever bizarre historic reasons. So now you go along, you've got your client list, you know the people that you're really concerned about, and you propose them for residential treatment, having worked with them for in a treatment order in the community. You've counselled them, you've provided group work, you've done everything you can for them in the community, but their problems are so deep-seated that they need residential treatment because they're not safe and things getting worse for them. So you apply for funding. Now, there's always somebody worse, and that person may not get funding, they get a knockback. Well, I did a study, and what I found, particularly among women, was they don't get what they need in community, often because the groups they're in are dominated by men. They disappear off the radar. They were in, their criminality was related to their substance use. Right? They disappear off the radar. They try not to commit crimes or not to get found out about their drug use. So then they reappear 5 years later or more. Now their mental health problems are far worse. And so this is attrition. You exclude the less worse, and what you get is the worst cases. Then now you've got to try and treat the worst cases. Well, A, it's harder to treat. You don't get such good results. You need a higher level of care. You need more sophistication from the practitioners. So you need a higher level of practitioners. So it's more expensive to treat. But at the same time, you've got pressures on funding that shorten treatment durations and impoverish the community. You know, cuts. The idea of levelling up hasn't worked yet. So you've got pockets. And in Surrey, we know where those pockets are, you know, for particular issues. You know, there's Guildford and Waverley, particular problems there, things over in Staines, particular problems there, and so on, you know. And then you've got the dichotomies between rural, suburban, and urban things, you know, East Surrey near to Croydon, you know, and then the drug corridors down from London through Croydon and so on. Then you've got problems to do with ethnic groups, you know, and so on. So as soon as you say we'd like to prevent admissions, you get then, and I've seen this in NHS QI training. I'm a trained Mary Seacole facilitator, and I've been through the regional Southeast region quality improvement training. And as a leader in trying to produce quality improvement. So what you've got is, in the training itself, they use it as an example, reducing admissions. And straight away, it's a misguided, what we used to call a shibboleth. It's an objective that's false. Admissions are going to increase whatever you do just because of demographic change. The more older people there are, the more admissions they're going to be from age-related illnesses and conditions. And that's what we're facing right now. What we want to identify is preventable admissions. That starts with an ambulance call out. What could have been done in the community? And therefore you need research. Now you've got a cultural problem, which is that mainly research culture is dominated by clinical institutions and academic institutions with a late runner social care institutions. Community agencies are mainly charitable in nature, and their income comes from charitable donations and from commissioning from local authorities. So you've got to have a policy if you want to reduce unavoidable admissions that starts with where are the avoidable admissions? In what kind of context are they? And so we desperately need research, but the voluntary agencies that are mainly trying to pick up the ball in the community say, well, we'd love to get some of this research funding, but we just can't even afford to look at what the requirements are, let alone bid for them. And if we buddy up with a larger partner, they take the lion's share. They've got all the clever people who are used to this kind of thing. So, you know, my suggestion, if you want to prevent avoidable admissions, is find out what's avoidable. And you can only find that out by seeing what happens in the community first. Where do people show up who are eventually admitted? And you have to track backwards. So you have to take, which is what you're doing, some research in the community, but not especially looking at inpatient services, but looking at what went before the inpatient was an inpatient. Did they show up at safe havens and get put off by something? Did they show up at their GP and be given the bum's rush? You know, like my partner and I, 6 out of 8 of our GPs in our clinic didn't have time for us. But the 2 that did were brilliant and got us what we needed eventually. How long do people have to wait? So at the moment, it's a very difficult question to solve because of public service cuts in the wider community. So even if you've increased the health budget, it hasn't really kept pace with population growth and the growth of social problems leading to the growth of mental health problems. And you still haven't got a good enough triage system that moves people through the system quickly enough to get the right resources when they need. And that's, I mentioned earlier, the meme approach. You're very likely to get through that a lot quicker by going straight to the people who are most affected by problems throughout their lives and seeing what you can do for them. Because anything that you do in that area is likely to feed through into increased well-being. If you make that the objective, instead of let's prevent admissions, you say let's increase well-being. Make that objective. I'm not saying you shouldn't monitor admissions. That would be ridiculous. but make your objective to improve the well-being of people who are frequent flyers, who are admitted, who call for the ambulance a lot, who call for IAPT a lot, who call for the CMHRT services a lot, who are regularly presenting in the charities in the community a lot, Mind, Richmond Fellowship, Mary Frances Trust, Catalyst, the Carers UK, the local carers in Woking, well, whatever it is, you know, get round to all those different agencies, Help the Aged, and so on, and then you'll find out who are the people who frequently present with problems, and put your resources, a little bit of the highest quality of resources there. And they've been talking about whether a psychologist should be on the front line in homeless services. Well, I worked on a project recently that was done in London where they weren't exactly on the front line, but they were very much present for outreach. And they met with the clients as a referral from street outreach straight into mental health services. And so mental health working with the outreach, the psychologist once a week meeting the whole United team, and then the mental health people were able then to identify people with residential treatment needs and take them in as inpatients, but also liaise, because it carries more weight. If you've got clinical letters after your name, then it carries more weight. But you've still got then the problem of attrition. So in a way, you're still admitting the most serious people, but what you're getting is at least a mental health professional has certified that their problems are serious enough to require inpatient treatment. But if an outreach team manager said that, it used to be they would receive the attention of the NHS and the local authority regarding social support and so on. I rose to be a senior manager in homeless services. It used to be that as just a humble prison worker, counsellor, I could write to welfare agencies, local authority housing and things like that, and try and get some services for the people who were about to leave prison. And occasionally I would succeed. Then in probation, I was a bit higher level and with a bit more weight, statutory service. Yeah, but then it started to be the housing people would say, you've referred 3 clients this week. Can you tell me which of them is the most serious, and we will accommodate that one. Then the other 2 were, you know, I've been to court, county court, and the judge has been watching this case for 2 years, and he's given a treatment order, and the person has profound needs. They're autistic, they've got quite severe criminal behaviour related to their drug use, but they've attempted to complete an order without a place to live. And 22 months into the order, we've still not been able to get them the accommodation that they need. And just as, well, you've tried really hard and I would like to help you complete the order, but you cannot complete it while you're homeless and living it on the heath. So I'm going to just, you've done well, I'm going to just terminate the order now and you're free to go. Goodbye. Well, that's not really helping much, is it? You know, the judge is just as appalled as everybody else. Then when I went as a senior manager, I'm speaking to housing directors then. I'm trying to get a house for one of my part-time workers who's living in a single-room flat with her growing son. And they forget it. They're saying she will probably wait 10 years. Maybe she'll get housed if she's still in the area when she retires and she's a pensioner. You know, so, and then we're being told, do not ever encourage the hope that anybody will achieve independent accommodation. That's not realistic anymore. So, you know, these are deeply connected issues. But what I found from my research when I was in the system was, if you've got multiple needs, there are likely to be multiple disadvantages. So if there's any criminal behaviour and it's associated with a history of housing problems, disabilities, educational challenges, relationship problems, other health problems, long-term conditions and the like, then it's very, very likely that that person has some kind of complexity of need, you know, trauma or something like that. So, but the thing is, in terms of frequent flyers and application permission, I've met people who've seen psychiatrists and been under treatment from psychiatrists, who've seen psychologists, been under treatment for psychologists, long term in the system, multiple years, maybe even decades. And then I say to them, it looks like you're having trouble organising your life now, and all your problems have multiplied, and you have sleep problems, don't you? And you have intrusive thoughts about these things that happened to you in the past, and you try and suppress and avoid those thoughts, maybe by using alcohol or other drugs and so on. And you've got a couple of other symptoms. One thing, you can't, it's all a jumble, isn't it? They go, yeah, you've summarised my life in the last 10 years. I say, has anybody suggested to you this might be a stress disorder, you're suffering from PTSD or complex trauma? I go, no, nobody's told me that. And this person's been treated multiple times by highly qualified, much higher qualified than I am. And if that happened once, I would just write it off to my own paranoia and my own problems. But it's just such a common occurrence with hundreds and hundreds of clients. And what's happening is the pyramid of attrition is that all these people with these problems are trying to fight their way through, and they keep getting bounced back. You get bounced from mental health services to drug services to mental health services to drug services to social care to this to that. Bounce. And people say it's like being in not just one washing machine, but you're tumbled in the blades. You know, I've met people with 5 different key workers, but the key workers don't know each other. They all think that they're the one who's handling the case. What is absolutely necessary is that all the organisations involved are able to give feedback about each other and the experience of dealing with each other as professionals, but more importantly, to get the feedback from clients, so that if you do an onward referral from one agency to another, you support them with a little bit of interim support and say, come back and tell me how your assessment with that person goes, and get feedback. And then you compile the feedback. In the end, after 2 or 3 years of hard effort, among a group of people who are willing and able like that, and are careful with their case management systems and monitoring, you will succeed in providing valuable feedback to each other and say, you know, when I sent these people to you, they all came back to me saying the same thing. And it's this. So could you change your system to match our system, because we never get that feedback. And then we get feedback from somebody else saying, you know, when you do this, when you give us a referral, we're missing a lot of information that we need. Now, sometime this month or next month, I'll be going down to one of these trusts, a charitable agency, and trying to provide their team with some training. The first training I'm going to be doing is about how to enable people to do their own assessment and tell you what they need, instead of you telling them what they need. Right? A tool that I worked on for years, developing it with the aid of clients, volunteers, staff, high professionals, testing it, delivering it, receiving criticism, modifying it, eventually succeeding. And it's just as valuable a tool to work among professionals as it is to work between a professional and a client. These are simple things to do. All it requires is personal, individual attention. It's the one thing we can't give, isn't it? Because funding cuts and the time it takes to actually establish real relationships. Because the relationship making at the moment is not systematic. It all resides in individuals. So while I'm passionate and in charge, I tell my people how they need to behave, or I ask them what they think would help, and then enable them, empower them to behave in the way that they think is most productive. And lo and behold, it is. They've solved their problem, and then they've brought the solution to me, and then I propagate it. But if I leave, is the next manager going to be equally as empowering? So you can't really empower your clients to interact with you in the most productive way for their own recovery and well-being if you're yourself lacking power. So it's so dispiriting to be assessing somebody for their MBQ and they're looking at their form instead of the client. The client discloses something horrendous or big, and they just go, oh yeah, and then write it down, and they don't even respond. And you go, oh, that was an important moment. Can you value it, please? Value your client. They were brave to tell you that. You shouldn't do that in assessing professional skills. But this is the thing: if it's not systematic, if I leave or that well-trained staff member leaves, the client will leave for sure, because they'll either get well or get worse and disappear. We've lost all those relationships unless it's systematic. And that depends on data systems. And at the moment, the data is a mixture of things, things required by different governments. Waiting lists. What the hell's going on with that? And then the juggling that used to happen under the Labour government, which introduced those objectives, caused so much problem. Waiting lists will reduce when your systems for treatment are more effective, and that depends on your systems for assessment, and that depends on your systems for referral, and that depends on the relationships between the system and the community. So you've got to fix a lot of those things, but the main thing that you need to fix is what are the causes of well-being? What do professionals do that increases the well-being of their clients? What can the clients do to increase their own well-being? And there's that trade-off in terms of responsibility. But you can't ask somebody with broken legs to run a race. They can't look after themselves properly if they're terribly mentally ill. And yet that seems to be the system, that we're being encouraged to take responsibility for our health and well-being. Hence, people smoke a lot, drink a lot, eat a lot, distract themselves with TV a lot, sedentary lifestyles and so on, all of which is causing higher morbidity on the back of a particularly high prevalence of mental health problems. So you've got comorbidity and early mortality, just because we can't take responsibility for ourselves if we're not well enough. It took me several years to realise I'd become seriously ill. And all the time I was getting bounced. So, and I'd seen that happen, but when it happens to oneself, that awareness is lost, because we're in the jumble of complex trauma and the stress disorders, anxiety and depression that go along with it. So we think, oh, I just need another job and then I'll be well again. But that's not true. Or I just need to go for walks and exercise and have a good diet. My well-being didn't improve very much. All the time I wandered in the woods alone. What I needed was a proper diagnosis. Now, I've been in residential treatment, I've been under the care of psychiatrists, I've been under the care of psychologists, but it took a lot of pushing to get my diagnosis of severe autism. I'm possibly the oldest person in the UK to receive a fresh diagnosis, a new diagnosis of that. So, you know, that's where we're at. And although attention is being given at the young end, and I think appropriately so, we should not leave behind all the adults who didn't get that attention and got the minimum of attention, the attrition. You're not so serious as the next person. We're going to give our funding to that person. We're going to give our best attention to that person. To me, that's making a rod for your own back professionally, because you're just building up ahead of more and more and more serious cases. So is it then surprising that you get admissions that are very difficult to treat? So there's a lot that could be done, I feel, within the present system to empower practitioners to have multi-agency working. And that's, again, what the meme approach suggests, to build these partnerships in communities to tackle the most serious subjects first instead of last or not at all. And then, in terms of inpatient care, not to be an island, to have vibrant relationships that are systematic with the coroner, with the CQC, with all the agencies in your community, including employers, always left out. But these problems build up. Half the people in the population or more are at work, aren't they? Prevention at work should mean good occupational health practices. And in my experience, these are terrible. I once was referred to an occupational health advisor who was in worse condition than me mentally. And, you know, we cannot afford that. You know, it's a global competitive problem now. Our economy is the worst in Europe at the moment, I feel. And our problems are the worst in Europe. And why? Because we're just still flogging that same dead horse. We let people become ill because we're not supporting their well-being. So again, you've got the well-being thing. Why don't employers, the good employers already do it, they assess people's well-being very regularly. And their supervision systems and their HR systems are all integrated. They're not different cities, not talking to each other. It's an integrated system, and their HR advisors aren't just firefighting by being in court all the time over unfair dismissals and people getting ill. They're active, they're analysing patterns. They're saying, oh, this person seems to take Fridays and Mondays off a lot. I wonder what's going on for them with these long weekends, you know. So, you know, good occupational health. We don't even think of that in institutional care. We're not liaising regularly with the big employers. Does the NHS ask Tesco's to donate to the charities that might help institutional care and help on the front line in the community? I don't know. I think probably not. Do the social care people, do the local authorities have any kind of charitable coordination? So they say, look, this charity is really important in our community efforts. We want to support it. Can the employers get behind it? You know, can they donate their time? You know, good employers already do that. They donate skills into the system, and instead of just taking out from the system all the time. But the majority of the employers are happy to rely on the NHS as the sump. All the problems filter down eventually into health. Environmental problems, transport problems, logistics, housing, ecology, economy, everything all filters down, and the illest people end up in residential care of some sort or another. They're admitted because they can't take it anymore. And some of them have been given a hard road to hoe, harder than the average. But do we work harder for the people who've had a harder time, or do we buy into the public kind of imagery of the Daily Express and the Daily Mail that says, these losers, they just need to get a job? You know, some people are more robust and more resistant to trauma and the like, you know, and it's the complex problems that you're going to see mainly on admission over and over again in mental health services. And then all that coordination again on discharge as well as on admission, you know. So I think there's hugely more we can do to help ourselves and help the clients of all our different services. And I would like to see, particularly our charities, getting more of a say in where the funds go, where the resources go, what the information is. But that usually needs, you know, really high degree of professionalism among researchers who are willing to get out there and find out who's actually in touch with the client group that contains people who are frequently admitted.
Can I ask, again, I don't really want to interrupt you because I'm learning so much, and you're a very good speaker, and you've had lovely analogies. I've written about the washing machine and bouncing from one service to another. So thank you so much. But so one of the questions is, what does good inpatient care look like, and what prevents this from happening?
Well, pretty soon after my friend Don, God rest him, told me about Inquest, I spotted a case that was in Surrey. And it was in the Abraham Cowley unit again. And somebody had completed suicide by hanging from a window frame in the inpatient unit. And the response from the organisation was to nail the window shut. Now, I find that response inadequate, to say the least. Now, I think it is possible, even in a very well-run organisation, for somebody to complete suicide if they're determined enough. I don't think that even the best organisations dealing with the worst cases can entirely prevent that. But I do think that that was a preventable suicide. And when I look at what happens in inpatient practice, you've got, by and large, a whole bunch of people who are motivated mainly by the desire to care for and help others who are in distress. I don't think they join and train in order to be careless. But there is a well-known phenomenon, and psychologists talk about it at Surrey University in the psychology department, practitioners, trainers. They talk about the idea of retreating as a team within one's technical sphere because of the pain, the distress of contact with clients who are so distressed. And what I feel has been the trend over the last maybe 20 years, and could be starting to be remedied over the last little while, is the idea that reflective practice and supervision should be identifying these issues and facilitating and empowering practitioners. So what we tend to measure, this goes back to things I said earlier about data, what we tend to measure is the work of care. How many of this did the person do? How many of that did they achieve? And then we measure what their outcomes were, how many clients got discharged, and whether they survived or not for some kind of follow-up period. Now, to me, again, that doesn't measure well-being either of the practitioner or the people they're trying to help. And what we're seeing, I've been in touch with some of the great and good of the NHS at very senior level, and they say, we didn't even start to worry about practitioner well-being until very recently. We just assumed that people come in, train, because of their wholehearted commitment to the idea of the NHS and care. And they're so strongly motivated that we've never needed to worry about their motivation. So the reflective practice, if any, has all been about technique, hasn't it? You've got nurses' circles. We invented reflective practice like that in this country. And then it was exported everywhere, especially in the field of mental health. In the 80s, it involved clients, empowering clients to provide feedback. And then the phrase was coined, nothing about us without us. And the staff of the time nurtured that. But then in the 90s and noughties, things changed, didn't they? And then we lost that esprit. And then people started to get a bit pissed off with the fact that the government taxes your pension, and the cuts, swinging cuts, mean that you can't discharge people because the social care on the other end is not at present. And now things are piling up for us. And I've seen mental health managers, qualified clinicians, spend all day on the phone going, I'll have a bed in 2 hours. Put the phone down, right back to my meeting. Oh, I'm meeting you, Eleanor, to try and coordinate with the hostel here. Oh, hang on, phone goes, no, sorry, I won't have a bed until tomorrow for that person. And that goes on all day. Now, what a waste. And has that person got then any motivation or time to facilitate staff to be in a relationship of care with their clients instead of the work of care? If he's lucky, that manager will look at his data at the end of the day and go, I've got this many beds now. And they're all filling up again. How is that person ever going to lead? So what I'm suggesting is in a quality improvement culture, everybody leads. As practitioners, we sit around the table regularly and we say, look, I've got these problems. The data system does not record what happens to these clients afterwards regarding their money problems, their housing, their this, their that. We need to make representations of social care to make sure all this is followed up. And then another practitioner says, well, I've just had this case and that case and the other case, and I'm really messed up about it, and I want to talk about that, and have a proper culture of reflective practice that's systematic, it influences the system. And then when all the practitioners are agreed, right, this is our solution, we're going to do it, and then we're just going to tell the managers what we've done and ask for forgiveness instead of permission if they don't like it. There's a lot more that we can do as practitioners and just say, no, I'm not doing that. I'm caring for my client here. Nobody can stop you caring for your client and establishing a relationship of care with the client. That's primary. How you do it and how you record it, you have to be safe. You have to be effective and you have to be efficient. So you can't just go for coffee with the client for a morning if your caseload is high. If you've got the leisure to do it, that's fine, isn't it? And you're going to get paid for it. But that's not practical in these circumstances. It's got to be safe. It's got to be effective. It's got to be efficient. Then you will have all the public good and safety and everything like that. So to be safe, effective and efficient, you've got to monitor yourself. You've got to monitor your caseload. How many referrals are coming in? How many cases have you got? How serious and severe are each of those cases? Is it a mixed caseload or are they all equally serious? How many people have improved well-being such that they could be discharged into community if there was enough community support for them? Is the community support available? And then what happens to the outcomes? You know, this was the person's well-being at the beginning, this was their well-being at the end. There are various axes to measure that, you know, and there's robust databases you could do that with. So you can analyze your own performance, go, oh, I'm not doing so well, or I'm doing reasonably well, or I'm doing better than average, you know. Oh, now I'm doing good, now I'm doing excellent, and I'm a leader. Now I'm going to propagate this this is what I do. Can't you all do the same? I'm monitoring my work. I'm using the data system to monitor my work. Now the manager can look at the team and go, well, we're monitoring across these things. And what's been proven to be effective from research is if you focus on these, all the other things will fall in place. So focus on these things, everybody. I know you've all got a report on all the rest of it, but just do the things that make the change first. Then if you've got time to record all these other things that I don't think make any difference or just required by the region or their government, then they have to justify why have you, you know, I was working in probation, I went to what was then the drug area team manager, team meetings every month, all the different arms of the drug policy of the time. And my administrator came one day because the manager had asked for data. And she had won an award for her data work. She was very clever. And she was just an administrator in probation, not even full-time on my job. And when the drug action team manager said, well, I want this and that and the other data, she said, I send you that every month. And he said, oh, do you? I've never seen it. I've never looked at it. And she cried because it was such a big effort for her to collect that data of all of us practitioners. So are you just collecting things for historical reasons? Does it make any difference if you stop collecting that data? Now, what do practitioners need to provide safe, efficient, effective services? What do managers need to keep the practitioners safe? And what do their managers need to make sure that the policy and strategy is being followed? And then what are the statutory requirements and the contractual requirements? And then you can renegotiate contracts because they're always renegotiated by the commissioners. The commissioner goes, oh, we've got to ask you to do this. Can you add that on? Well, now there's got to be some justification for that. And how much of an extra overhead will that cause when we're recording all this extra stuff? Does it make any difference? So that's a research question, isn't it? Which activities improve quality of care, improve well-being, improve outcomes, what's the causes of outcomes, what measures outcomes themselves, and what can be dispensed with because it's being recorded just because it used to be recorded. So you know, I think there's some useful developments that could be made there, but it all comes from a culture of professionalism, competence, leadership, communications and reflective practice skills, and these skills are trainable and they're amenable to cultural change, and it can change a whole culture. And I succeeded in doing that just by saying, well, let's all talk about this as a multidisciplinary team, and then we'll make some recommendations. And then we got somebody in to facilitate us, and then that method proved to be so successful in terms of building morale that it spread to the whole organisation. Then we changed our database to better reflect what we're doing with clients, and that allied itself with a strategy that instead of pursuing what the government want to do, we're going to look after our clients and try and help and promote their well-being. We're going to address their health issues. We're going to help them to live healthier, happier lives. And, you know, to some degree, having that as a mission is to reducing emissions. Or you can't increase outcomes by looking at outcomes. If you just look at the outcome, all that will happen is you'll see outcomes, and you'll see that whatever you did earlier produced those outcomes. What you really need to know is what produces good outcomes and what produces poor outcomes. And I'll tell you this, somebody hanging from a window is a poor outcome, and it reflects a lack of the relationship of care and a focus on the work of care, returning this many statistics, doing that administrative task, measuring these things and those things, instead of measuring the quality of the relationship of care. And if you want to measure that, you need to involve clients and the CQC, the inspectorate, the statutory requirements, and so on. And they're taking a big step forward at the moment, but to me, it's only one step. It needs a couple more steps before it becomes really effective and moves away from, again, the culture of we'll all become orange. Yeah, you know, there are some green performances where high quality, good or excellent performance, and there's some bad performance, red. And it all ends up as an average of orange. Well, we've got to surpass that and go, I want to be the best. I want to achieve, whoever is achieving the best, I want to achieve the best with them. And I think I should go to Northumbria and look at how they're dealing with things. They've got roughly the same health resources and social resources. In fact, they've got less social resources because they're unequal in terms of the kind of gaps between, you know, it's the gap that's to be addressed by levelling up. You know, we're all rich in the southeast, they're all poor in the northeast. And yet they're doing some good performance over there. I wonder how they're doing it with the same or less resources that we've got. And their client group is equally impoverished. So how are they doing these good resources? How are they performing? You've got to start that debate. And there are some national organisations that can inform us. And MEME is one of them in terms of mental health for people with profound and long-term problems. Making every adult matter.
Thank you. So our last question, because I haven't had to prompt you because you've covered a lot of things that usually we have questions for. So thank you for that. And again, thank you for such in-depth answers. You really know your stuff and presenting kind of a systemic analysis of the landscape in Surrey and mental health in this country anyway, as well, sorry. So what does good timely discharge look like? What are the barriers and what improvements could need to be made?
Okay, timely discharge, barriers and improvements. I think the clinical framework and the social care framework need to be more closely aligned. The timely discharge, really, I think many clients, certainly me, certainly my partner, dread discharge if we don't feel ready. So even within a community setting, people are discharged routinely and kind of casually sometimes, without really verifying that the person is okay to be discharged and has enough support regarding whatever ongoing problems that they have. So to be timely clinically, people focus on the clinical time between admission and departure. That's their sphere. And it doesn't take a genius to see that that's only a partial picture of the individual and their needs. Probably their admission, certainly in today's circumstances, might have been delayed anyway. So they didn't get a timely admission for a start. So their overall well-being related to their admission is lower than it could be. So part of timely discharge is timely admission, isn't it? And there are all kinds of barriers about that. But ideally, every clinician knows that they will discharge their client unless their client dies during care. And it's one of the things we have to accept as professionals, isn't it? That we're going to meet a client, however well or badly it goes, then they're gone. And we have to move on to the next one. Or we're probably juggling a few dozen plates at once, you know. So timely discharge for me depends on timely referral, timely assessment, timely admission, and really good checking that we've got the right information when they arrive. Now, a while back, I did some Health Watch work as a volunteer, and one of my colleagues in a group that I was in London, a PPV group, Patient Public Voice group, happened to live in the same area as me, and he had eyesight problems and he needed surgery, and he went to St Helier for his surgery, and he's on the operating table having fasted and so on, and then they look in the drawer and they haven't got the right thing that they need, and so he had to get up and go home without his surgery. And a few months later, there he is back laying on the operating table, and it happened again. So I would say that was untimely discharge twice, because he didn't get what he needed. And so part of being timely is to make sure that all the right steps that are needed for discharge are in place when they're admitted, isn't it? And you can do a lot of planning, can't you? What is the social context of the individual? What do they need? Now, my mum died, and in effect self-discharged by dying, from a hospital because she didn't get the right care. Now, it wasn't a mental health hospital, but they were treating her as an able-bodied person who's just recovering from pneumonia, rather than somebody with MS who couldn't move their body properly. She couldn't breathe. She choked to death with her breakfast. So that's untimely, isn't it? Now, she would have died eventually of suffocation because of MS, so that's typically how people die. But she was immobilized for several months earlier on that year, which weakened her musculature around her chest and therefore weakened her breathing, which made her more susceptible to pneumonia as the winter approached. So timeliness includes appreciating the context of the individual that you're admitting. It's not the same for everybody. Now, in the NHS, they're trying to catch up with a lot of surgeries, aren't they? And so we'll make a production line issue of it. But if you've got any complexity, we can't do that for you, and you'll have to go on a separate pathway. Now, that's what should happen for everybody. Is the separate pathway should be their personal pathway, judging their health conditions and their social contact, their abilities, their overall well-being, and the things that contribute to it. Making the assessment, then seeing how that changes at points during their treatment until it's approaching the time for discharge, checking the assumptions, discharge assumptions, making sure they still are all applicable. So the barriers are you might not know enough about social context because you've got a clinical focus. So what you need then is integrated care and coordinated care. So coordinate with all the different people who've dealt with this person. It's very hard actually to find anybody who's an adult in their 30s or so on, maybe 20s, maybe teens in mental health services who hasn't presented before to some degree or another. So the obstacles to discharge then, timely discharge, are whether the responsiveness of the community agencies to the discharge needs has been primed or not. If they've got the capacity, then they should have been alerted to receive the person. So then you've got the in-reach contract, and that needs to be knitted in. But at the moment, CQC, when they're assessing a hospital, say a mental health hospital, they assess the mental health hospital and they assess its admission and its treatment and discharge protocols and how are we doing, right? But what they don't assess is the community agency and the community commissioner who's put the umbrella contract in place. So they've got the Mary Frances Trust, Catalyst, Richmond Fellowship, etc., and an in-reach service and Citizens Advice Bureau Mental Health Department, all helping the individual to be discharged. So come and visit, establish relationships, bring them forwards, send them back, easy in, easy out. Well, it's easy for me to say easy in, easy out, but I don't know that it's ever been achieved properly in this region. I know from my experience just on community-based treatment, it's very difficult to access, even if you've accessed it before, and even if your GP is on your side and says, look, we really need this again, it still takes probably 9 months to a year. Now I can go down the road and walk to Safe Havens and say, oh, I'm in a bad way here, can you get me a clinician? And they'd probably be able to get an arrangement with me immediately for something. But then to get back into psychological treatment or into residential care is still going to be a problem. But presuming that I do get residential care and get through it and out the other end safely and efficiently and effectively, and my problem is reduced, will I be able to go round the loop again if I need it? And that's really the big issue, I think. That's a big barrier. And what you'll find, and there's been a little bit of research and experimentation done, is if you reassure a person that they can fall back, it seems to uphold their progress onwards. So just having the capability, the reassurance, okay, if you have any problems or this recurs, contact us, come back. Now, in drug treatment, aftercare is a regular thing. I'm an advanced practitioner in drug treatment. I'm still accredited because I still pay my membership. And but in rehab, I had the benefit of aftercare if I needed it. Now, I didn't access it at the beginning. I thought I didn't qualify for something inside my own head, not because of any difference between me and the other people who were accessing aftercare. But eventually I went along to aftercare. I was encouraged by my friends, and it was a huge support. And because they maintained a close relationship with the unit discharging into aftercare, that made it special. It made it good and effective. And that's what you need. It goes back to what I said earlier about relationship. If you're discharging to known people and they're reliable, you won't hang on to your client for fear that they won't get a good ride. You'll say, look, you know these people, they're effective. Go and try them out. Come back and tell us what you found. And if you've got any problems in the meantime, talk to us and we'll support you as much as we can. Just that guarantee allows people to move on if the move on is positive. But what tends to happen is you get discharged from a service. Now you're waiting for the next service, and now there's a gap. And before I know it, I've fallen back into my old ways, my old habits, and Now it's the same grind. Now I need the psychological treatment all over again. And this time there's some aftercare or something changes for me more radically, and now I'm okay. But getting back was a struggle. So that's, I think, the biggest obstacle. And the improvements I think that can be made goes back again to multi-agency reflective practice, effective supervision models, effective group work with client groups, effective individual work to support practitioners, effective management developments, some kind of unification of policy and strategy, more up-to-date data that actually reflects what trends and where we're going and where we've been and where we are right now, and doesn't overload people with, you know, just data visualization is a barrier if it's absent, you know. And I've worked on boards in Surrey with suicide prevention and the development of the social care model for social care support for people with mental health problems. And consistently, the information technology part of the work plan has been in arrears. So all the data is being collected, but how it's put together and visualized, you know, and then you've got clinical organizations that spin the data or keep it to themselves. Freedom of information requests all the time to Parliament asking for data that really belongs to us. It belongs to NHS, which is ours. We've got to try and achieve what I said earlier about the, you know, forming a picture out of the data that's supportive of practitioners, managers, policy development, the inspectorate and regulator. You know, we've got to make it work for everybody, including clients and carers, patients and carers, so that when we ask for information, it comes straight back and say, how many carers got helped in Surrey this month to look after somebody who was discharged? Now, I bet you anything, it's hard to find out. And the reason I know it's hard to find out is a similar interview like this a couple of months ago, where I asked a question at the end from a researcher who I knew was in the integrated care system. And so, just as a matter of interest, can you tell me about how is the data on that? How easy is it to visualize? Is there graphs and all that? Can it be obtained? Good question. We're struggling, they said. You know, researchers are struggling. They're professional researchers, qualified, and used to the ropes of academic and clinical culture. How much more difficult is it for an agency like for Independent Mental Health Network or the volunteers within it to be tootling away on our computer going, I'm really concerned about what so-and-so said about the discharge system from the mental health unit. And they're so worried that the person's going to come out and not get the right support. Wonder what the general picture is. Bad to argue on the basis of difficult individual cases. What we should do is something systematic. How are carers being looked after? Does the integrated care system produce to carers who are going to have somebody discharged into effectively their care? I know it says the GP is on the care plan, but the carer is the one at home who's going to feel the brunt of it if there are problems. You know, did they get the right support plan? You know, so these are questions I think that reflect on things I said earlier about having integrated systems that really work well for everybody and everybody has contributed to them. And the reflective practice in the end has to include feedback from patients and carers and some kind of co-production, you know. And next month, me having a co-production conference, and there'll be a lot of professionals from all over the country attending either London or Manchester to talk about these problems. And they'll show a video that I've made. I'm now wondering if I can get a copy of this recording so that I can use excerpts for other purposes to help other areas of service develop. So I'm not sure that that's possible within your research mandate, but perhaps it is.
I mean, that co-production conference sounds really interesting, and we've tried to make this project co-produced. I'm sure I can send you a copy of this recording.
It's going to be a mega thing. It's getting on for 2 hours now. We should really stop.
That's okay. That's okay.
But it has been fascinating, and you know, one of my abilities, perhaps not so much nowadays, was that I could see the steps in a project. If somebody gave me a brief and said, "We want you to set up a new group, and your brief is this, 2 lines, save that system over there, create a new system over here." I go, okay, and I'd start my thing. I said, right, I think we're going to need this and that and the other, and start building the system, and then change it around a bit, and then realize that there's something important I've missed, start again, and then establish a system, and then codify it, build up the building blocks, and then create a whole system. Or I could look at a whole system and go, well, there's a flaw in the building block over here, or that isn't pulling its way over there, and so on. So that, if you like, that is a talent mind. System design, system engineering, planning, development, innovation. And I've just assumed that everybody thinks like that. But for a lot of my life, I now know people don't think like that. They're usually enthused about a particular aspect of something, and they're good at that thing that they do. And then they need encouragement to look at things that I'm enthused about, like how to build a data system that supports all the different levels, you know. So having co-production, I've just assumed that co-production is a value that everybody should adopt, because when I went to rehab, that was the system that they used. They were professional providers, and they included their clients in everything. And we'd go to weekly meetings about how the system was and how it should develop. And, they'd have elect representatives, or they'd be chosen for us sometimes, and worked really well. And I just assumed after that all the mutual support groups that I went to were the same. They would involve us all in trying to help the system improve. It sort of came as a shock to me when people started to question if I brought a client representative along with me to a meeting or something, and they say, sorry, you can't bring that client along. I said, well, I've got a history of mental health and drug use and so on. So, well, so have I. I'm the manager. You're going to exclude me from the meeting that I'm invited to as well. And they go, oh, I suppose not. Okay, well, you better come in. Now, making every adult matter, they've got a structure, and these events, they call them the learning hubs, and there'll be lots of different partnership workers and managers from all the different streams, police, health services of various descriptions, housing, social care, and all the like, going along to these learning hubs. And they'll be talking about co-productions a large chunk of the day. And it's built in. It's assumed if one of their staff was to not do it, that would be a shock to the system. And the staff would be grilled, why aren't you doing this? But elsewhere, there are various levels of aspiration. In Surrey, there's a paper coming out soon, if it isn't already released. There's probably going to be a lot of problems with it, but I helped to contribute to it. It was commissioned by Surrey and Borders Partnership. They interviewed staff there. There was a whole separate thing that I did about a survey of what succeeds in mental health regarding co-production, what's been a success anywhere in England. So I wrote a review paper on that. But they did interviews with staff, they did interviews with other professionals in allied organisations, did interviews with clients. And the staff experience in this paper, I received a draft, but it's embargoed at the moment. I suppose I might be able to share it with you subject to restrictions on confidentiality. But the idea was some of the staff were saying, yeah, we do co-production. The clients contribute to their care plan. That's not co-production. That's just involving the client in decisions affecting the client's care. It's not the same as co-production. You could say they co-produce the care plan or they co-produce the discharge plan, but that's not really co-production, is it? Co-production is when you involve patients and carers in the system, in system improvement and system design, system change, proper co-production, full engagement, equal power over the system. Now, practitioners want there to be effective systems. Practitioners want to deliver effective care, personalised care to each client according to what the practitioner thinks is best professionally for the client and what the client's options suggest the client would be happy to receive. So in a sense, the client and the practitioner are allies, but the alliance is stymied in the end by the fact that there are systematic obstacles to them both doing what they want to do together and recording that and its outcomes, because the system wants something other than what the client and practitioner think are best. And that's the whole reason for the kind of IAPT problems in the past, and the bounce and the gaps. So, I do think, when Surrey and Borders staff say, oh yeah, there's a head of co-production somewhere, but I don't know what they do, and it certainly doesn't affect my work. I would never dream of having clients involved in this abstruse stuff that I'm doing over here. They don't know what they're talking about, do they? They're all mentally ill, aren't they? That kind of thing, So you see a whole range of things, from completely committed, enthused engagement in co-production to complete hostility or absence of any knowledge of what it actually means to really genuinely co-produce something, and how effective that could be. And then, of course, there's the wider absence of much evidence. This week I've also received the CQC video from their engagement with the public on the launch of their new inspection program, how it develops and how it's going to be delivered. And I got the video. It was a couple of weeks ago, a week or so ago, the interview. And it's a video, but it doesn't, to me, reflect half of what everybody said. It's a summary. So you've got an introduction to the scheme that lasts half an hour, and then a discussion among some talking heads, which is summarising our input. But my face isn't in it. I don't see myself, and I don't hear myself in any of the comments, a lot of which were made in the chat between us. And that's the thing, isn't it? When you do genuine co-production, what you're allowing is the possibility that people like Eleanor will speak to Eleanor, and Eleanor will speak to people like Eleanor, and people different from Eleanor with different opinions. And I'll say, well, in my local charity we do this, and they go, oh, that sounds awfully traumatic to me and hostile. Can you not do it in a more friendly way? I go, well, I'm going to suggest that. Thanks for pointing that out. And because what we're used to, we get used to, and then it becomes the norm. It's not necessarily good.
Eleanor,
Hello?
Thank you so much for sharing your experience and your knowledge. I'm just mindful that I've got to end this interview in 5 minutes. Is there anything else you would like to share with us?
Okay, well, I think we need to encourage volunteers to participate, but I think we should exercise the budgets that NHS provides and that local authorities should provide, which they often don't. So that input like the input that I've just had, or all the different examples that I've provided, is recognised. Its value should be recognised. Its intrinsic value in itself. Never mind the outcome of whatever comes from this, but just our conversation has a professional value, and that requires to be professionally valued by some kind of reward. Now, because I do this sort of thing a lot, I tend to forget any promise of rewards or whether I'm doing it in a voluntary capacity. But to me, we've just had a professional conversation that's gone quite deep into some of the subject matters and draws on my professional and my lived experience in a way that you couldn't avail yourself of for somebody who's just fresh out of treatment in the last couple of years. Do you see what I'm saying? I don't think I need to labour the point. There is an allowance for people to have their expertise rewarded. Now, the NHS makes that a policy. I think local authorities should. Surrey and Borders tends to take it for granted. They think that just by paying expenses to a volunteer for something, say I turned up live down in Leatherhead and done this, they'd give me £4.20 for my fare, and that would be it. Well, you know, and I've had the similar experience with a local authority producing a video, a half-an-hour video on strength-based training that took months to prepare. Professionals and myself interacted. We produced the video. As far as I know, it's been used for training. Will I get a reward? No, I got a box of chocolates on the day. Thank you very much for all your effort. Now, that to me does not respect individuals' expertise in communication, in leadership, in motivating change. And that's what I'm trying to do here and now, is give people the appetite for change and make it a positive thing, not something to be resisted. So, you know, more power to your elbow. I hope that some points emerge from this, but I think that would be my last thing, that there is clearly a role for volunteers, and I do a lot of volunteering and I have no hope of reward, but I hope that my participation has helped somebody. But then there's on the other side of the boundary, there's what we've just done, which I think is a combination of lived and professional experience with a lot of expertise involved that should be recognised as such and rewarded as such. So I hope you get your rewards for doing your work, and I hope that I will eventually get my rewards for doing my work. So, but it's been a real pleasure to have you listen to me, and you've been a very patient listener and a very good prompter too.
Thank you. I've enjoyed it, and I haven't. Thank you. I've really enjoyed this interview, and when I've been typing or writing, it's just kind of nice things you've kind of mentioned that to be aware of. So, do you have any questions following this interview?
Do you know when the conclusion of this will be reached, and in what form the output will be?
So we're hoping
not
to
this
finish
interview, but the whole project.
So we're hoping to finish the interview, not the interview, sorry, the report by the end of October, and then it will be submitted to Surrey Heartlands. But we are also, I suppose this week, thinking of different outputs. So we will put some of the findings online, but we're thinking of ways to make it quite impactful. So that's so that's where we are at the moment. Do you have any other questions?
Not really. I'm going to look forward very much to seeing what survives of our work together.
Yeah.
And, you know, I really wish you the best for this, because it's a serious issue that deserves a whole lot of attention. And
Yeah.
my experience is that summaries often don't do justice to the detailed considerations that are needed to improve the system.
Yeah. Thank you so much. How are you feeling now that you've completed this interview?
Well, I'm surprised that my responses have been so much welcomed, and I will take this with me, and hopefully I'll be able to make use of the recording to try and remember some of the points, because it does seem that allowing me some kind of free-form responses has produced some meat somewhere in there, and I think it'd be good to organise it and condense it a little bit into something that we can use for the future.
Yeah, I've just so I think it will be fine, but I've just emailed my the research supervisor to just say, is it okay to share this? But I don't think there should be any problems, considering it's your data as well. But I'll wait until I hear back from her. So that's, you said you were surprised it was welcomed. Could you just explain that a bit? I'm a bit surprised by that.
Well, one of the things I did in the summer was I facilitated an example reflective practice session for a body of people as part of Research Week for the Applied Research Collaboration for Kent, Surrey and Sussex. Some of it was, the event week was online, and some of it was live. And I did an online reflective practice session. And one of the issues that was identified by people in the field who are trying to get engagement and co-production going, and or just conduct research among patients or the public regarding health and well-being, was it seemed to the professionals a little bit arbitrary as to what got selected and what got rejected in terms of research subjects' input into things. So that was a phenomenon that I noted, and for myself, having had recent experiences where the work products don't appear to contain anything that I said, and it's easy to condense things wrongly. That was one of my first experiences of co-production or engagement. Was we're all on the cafe table kind of discussions about things, and there was a patient with particular experiences relevant to the thing who said this, that and the other, and I made notes of it because it was very vivid. And then when the summaries got put together, the people summarising from our table said, well, it went like this. And then the patient stood up and said, no, I didn't say that at all. What I meant was this. And it's the bullet point mentality that follows the cafe style discussion. You know, you've given ample time, and I don't usually get that time, to be honest, because I digress frequently and thoughts become conjoined and lead from one thing to another. It's all kind of joined up for me. So often I'm cut short. So that was the surprise, that that you don't seem to be bullet pointing, cutting me off when I've reached a point where you can say, that's a soundbite I can use. Thank you very much, Eleanor. And off you go, you know. And that's very welcome, that approach to me, because, you know, what I say is all of a piece, and you might disagree with some of it, and some of the points might be less valid than others. Some of them might be supported by evidence, and others are just my own conjecture. But in the end, you've listened to it all. And what I welcome is that approach. Not for every piece of work that we do, but sometimes there should be time to delve into things and unearth and go deep into things and explore knowledge and where it might lead to. Some of the things I've said are only signposts really to other subjects, you know. So, you know, this is terrible for a job interview, but brilliant for qualitative research, isn't it?
Yeah, that's well, thank you for your feedback, and I'm sorry people haven't given you the time or interrupted you in the past. That doesn't sound very nice.
Well, that's not your fault. There's nothing to do with you. That's people with their own agenda from the start. You know.
Yeah,
I've made my conclusions. Now tell me what you think. And then they'll fill that in as a soundbite, and a member of the public said this, which supports my conclusion that. So well, I know that that's not you now, because you've had the patience.
It's okay.
Okay,
well, thank you so much.
And thank you so much again for listening and for being so amenable.
That's okay. That's so I will send you a debrief form, and I've just got a few points just to clarify that. Is this the program you were referring to, with a link to make sure it's the right, it's the same thing. But thank you again for sharing, and I hope to see you again around.
I'm sure if you're around on the scene of mental health, well, we will meet each other sooner or later. Maybe at that hub, if you apply to MEME, you've still got a chance to join. It was going to be next week or the week after, and it's been postponed till October now because of train strikes. But so you've got time to apply, I think, if you want to find out what goes on among interdisciplinary working across the whole nation regarding a particular mental health approach.
Great. I will definitely look into that. Thank you so much.
I'll introduce you if you like, and you can get.
Pardon?
Or you can just say, Eleanor told me this was going on. Am I allowed to attend? We've got a MEME project going on in Surrey, haven't we? Changing Futures thing, which is the same approach. So I guess you would be welcome there. I'm a researcher in Surrey. Can I have a place at your conference? But it's a physical event, either in London or Manchester. So I'm assuming you would probably be able to make London. If I detest the place, I'm never going there again if I can help it.
Are you going to Manchester then?
No, I'm not going to Manchester either. I've sent a video. The video is going to be the pivot for the whole of the day's discussions, as far as I can tell. So you'll see me again there, but only on video.
Oh, that's okay. Okay. So thanks again.
I would sooner go to Manchester than London, but I have a conflicting engagement on the Manchester date, and I'm free for London, but not going.
Oh, okay. Well,
okay.
Again, thank you so much.
It's good you're leaving me with a smile, albeit frozen.
Oh, good. Good.
Okay, bye for now.
Thank you. Bye.